So thank you for inviting me to come along and speak, and thank you for coming along to listen. I have a whole hour, which is quite a long time to talk, I think. I'm keen for this to be relaxed. I'm really happy for people to interrupt me at any time. And hopefully, I don't think I've got enough slides to take me the full hour, so there's plenty of time if people want to ask questions or share their experiences. In terms of disclosure, I do consult for Genea Fertility, who have one of the biggest PGD or pre-implantation genetic programs in Australia. I'm not part of their business, I'm not part of the company, they don't pay me, but obviously I consult for them because I think they do a good job, but there are plenty of other people who do a good job as well. So I really love this slide. In the area that I work in genetics, technology is absolutely flying along. And most of what I do is kind of run behind technology, trying to make sense of technology, trying to get my head around the ethics of the technology, of what's acceptable and what's not, of what's appropriate and what's not. And I used to joke that on my way into Genea, before COVID, when I actually went in there to see people, I'd ring them on my way in every Tuesday morning to see what technology they were using on the embryos each week, because it just changes so rapidly. So, I mean, obviously, planning a pregnancy is about choice. And many people with all different sorts of genetic conditions choose to not worry about any kind of testing. And that's absolutely people's choice. My focus today is more on the options for testing or avoiding having a child with a certain condition. But I don't want to impart any kind of judgment with that is the only way forward. I am going to talk about IVF with pre-implantation genetic diagnosis because that's loud and clear the option that most people have come to me wanting to know about today. But I will put it in the context of more traditional methods of testing in pregnancy, so prenatal diagnosis, and also potentially in other options for testing during a pregnancy with non-invasive prenatal testing. So there are lots of questions that people might ask in this situation when planning a pregnancy. How did OI happen in my family? I'm going to interchangeably use the words OI, bone fragility, brittle bone. I hope that, and I know not everybody has OI, not everybody's the same, but I'm just going to interchangeably use those words. Could other family members or future children have a similar brittle bone condition? How do we think about gene testing as the first step in planning a pregnancy? Can we test for it in a pregnancy, or can we avoid having a child with this condition altogether? So most of this starts with a genetic counselling session, and there's a lot of confusion around what genetic counselling actually is. It's not counselling in the traditional sense, although there is a lot of talking and decision making that goes on, but everybody's experiences are unique and completely different. And so I'm not a genetic counsellor, I'm a geneticist, so I'm a doctor, but I work very closely with genetic counsellors. We work together, and genetic counsellors have scientific background and counselling skills, so we work as a team. And our aim is to provide information so that people have choice, to help people process that information and to make a decision for them that's aligned with their own family's beliefs and experiences and needs, but this can be really stressful. So I'm just going to do some basic genetics just so that when I'm talking about tests and things that we have some basis on which to frame that. So very basically a gene is a code or a recipe that makes a protein. And almost all genes, but not all genes, make a protein in the body. Normal genes make normal proteins, genes with mistakes in them, or missing genes either make no protein or they make a protein that does some harm in some way. It might muck up the way a protein functions. So there's sort of two ways that genes can have problems. One, because they don't produce the product that they're meant to produce, or two, they produce a product that causes a problem. Professor Salent sent me this yesterday. This is the current classification of genetic forms of osteogenesis imperfecta and heritable bone fragility disorders. Obviously, I don't need you to actually read this at the moment. But first I wanted you to see the complexity of the genetics. And whilst, which is the laser, no, that one, yes. Whilst the common things are common, these, there are just many, many different types of OI, but also different forms of inheritance. So this column here tells you that these are autosomal dominantly inherited. There are lots of recessive ones, and there are some X-linked ones as well. And so I'm going to briefly cover all of those forms of inheritance, but then I'll talk about them together. So just in general terms, genetic conditions can occur in us for the first time when we're being formed, or they can be passed on from a parent to a child. Once they've happened for the first time in us, then they are passed on in the same way as if they were inherited. So they are all heritable, they're all genetic, some are new, some are inherited. Don't know why that says bleeding disorder there, I think we'll just ignore that. So genes are packaged into chromosomes. So I think of, so here we've got a cell, and there's a nucleus in the cell, and these chromosomes, which look like little worms, are floating around in the middle there. And there are a thousand odd genes lined up on each of those chromosomes. I think of chromosomes being a bit like volumes of an encyclopedia, and the genes are like the pages. So the OI gene is just one page of one volume of the encyclopedia, well, all the different OI genes, and when scientists look at them in the lab, they line them up, biggest to smallest. They number them 1 to 22. These are called the autosomes, or the numbered chromosomes. And then you've got your sex chromosomes, and females have 2 X's, and males have an X and the Y. And you see you've got 2 of each chromosome, because we get one from our mum and one from our dad. And the eggs and the sperm are the only cells in the body that only have 1 of each, so that you end up with 2 again when you have fertilisation. So chromosomes, big picture, volumes on the shelf, genes, single pages, and every gene is a separate page. And sometimes the mistake in a gene can be as simple as a T instead of a C. These are not big mistakes, these are little spelling mistakes that cause so much grief. So the 3 broad different ways conditions can be inherited. So autosomal dominant. So dominantly inherited conditions are typically those that run through families. They're generally milder, but not always. And there's a 50-50 chance of passing it on with each conception. And as I said, they can be inherited or they can be de novo, which means that when we test the parents of a child who has a particular condition, they don't have the condition in their blood. The tricky thing in here, and I'm going to come back to this, is sometimes you can't find a genetic change in the blood, but it's actually hiding in a pocket of cells with a mutation in the ovaries or the testes. And that's called germline or gonadal mosaicism. And that's how a seemingly unaffected parent can have 2 affected children, because in this case, the genetic change is hiding in a pocket of cells in the testes. Autosomal recessive, so many of those rarer forms of OI are recessive, which means that you have to have both copies of a gene not functioning to get the condition. These ones tend to come out in the one generation and tend not to be passed on because they're quite rare individually. And you have to have both parents carrying a change on the same page of the same volume of the encyclopedia. And then you've got sex-linked, and as I said, I'm going to come back to these, where healthy females can carry the change and it can come out in a male. So this is just looking at it in a different way. You've got here an affected parent, has 2 copies of a chromosome that has 2 copies of a gene. One has a spelling mistake, one doesn't. Half the sperm get this copy, half the sperm get this copy. So really it's like tossing a coin, 50-50. Either a sperm with the change fertilises an egg and the condition's passed on, males and females equally, or the sperm that doesn't have the change fertilises an egg and it isn't passed on. If it...
A question about that?
Yeah.
So with the unaffected child
Yep.
on the bottom
Here?
would they be passing on OI?
No. So if they don't get it, then they can't pass it on. So OI can be very variable clinically, so you can have people in the same family that have many more problems than not, but they will usually have something. In other words, it's usually completely penetrant. I hope I'm correct here. Usually most people will have, but it can be very variable. But if you don't get the gene change, if you're formed from one of these sperm, then that's that. You can't pass it on. Yes?
I agree with you, sorry.
You go. Go on, you go first.
Oh, no, we, back in 1980, we had genetic counselling, and they said it was 50% chance, but they said then that if our children did have it, it would be as severe as my father's and mine, and that was totally untrue. Yeah.
We've learnt a lot.
There's been lots of different degrees of type 1
Yeah.
family, so we've got 13 family members with it.
Yeah. Yes, up the back.
Sorry, I forgot you said we've got plenty of time. I didn't want to interrupt before. But on the previous slide,
I'm coming back to each of these individually.
but on the no, sorry, the one before that. It was, you circle as your female and you square as the male,
Yes.
but you had 3 on one line.
This one?
No. And there was children coming from that, and I'm like,
So the way these pedigrees are drawn, the circle is the female, you're exactly right. The squares are the males. The coloured in means affected and non-coloured means unaffected.
there was a chart where there was children coming from a row of 3.
Well, let me do the next 2 slides, and then if it doesn't become clear, I'll go back. So 50-50, like tossing a coin. You can get 3 heads before you get a tail. You get 3 tails before you get a head. If you do it enough times, you probably get roughly 50-50, but it's really variable. This is thinking about when a child is the first affected person in a family, and we call that de novo. And you can be, this is what this might look like. You've got an affected child, and neither parent carries it in their blood. But what we know and people have been caught by in this situation is whilst testing in blood is negative, there's a pocket of cells in the testes or the ovaries that carries the variant that we can't find and then results in having another child with the same condition. And actually this varies. In some conditions it's quite rare. But actually in the collagen, COL1A1 and 1A2, this is actually relatively common. A little bit like in Duchenne muscular dystrophy, which is the field I mostly work in, that it's not at all uncommon to find these pockets of cells in the ovaries or testes, and that happens in about 16% of families. And if it's there, then they have up to 50% chance of having another affected child, even though they're well themselves. So this is why genetic counselling is important. This is recessive inheritance, so we all carry recessive conditions. We all carry many of them probably, and because in recessive conditions, the second copy of a gene acts as a backup. So you've got one mistake on one copy, the other one acts as a backup, and we all carry them when we're all fine. It's only a problem if a child has both copies with a mistake on the same page, so they've got no functioning copy of that gene. So here, and cystic fibrosis, spinal muscular atrophy, there are many, hundreds of recessive genetic conditions. So these tend to come out in the one generation. So here you've got a parent with a mistake on one copy with one that's functioning normally, the other parent a mistake on one copy. If this sperm fertilises this egg, then this child has no functioning copies of the gene and has the condition. But if this sperm fertilises this egg, then they're just a carrier, and so on, and this one's a non-carrier. So there's a 3 out of 4 or 75% chance of healthy children, and a 1 in 4 or 25% chance of a child who has no functioning copies of the gene. And again, there's a lot of luck in this. So whilst most people, they tend to have healthy kids, there are some families who have 3, 4 children affected all in a row just by chance. And whilst these children now have no functioning copies of the gene, it's only an issue if their partner has a mistake in the same gene. And because these are individually rare, this is not very common. It happens, but it's not very common. And with testing these days, it's relatively easy to check a partner to see if they carry a change in a rare gene, but the chances are relatively low, unless, of course, you are related by blood, and a lot of our population is related by blood to the people that they partner with, and that increases the chance that you will have inherited a mistake on the same page. This is a much rarer form of inheritance in OI, an X-linked inheritance, where, so we have 2 X chromosomes, females do, and males have 1. We don't actually need 2 most of the time, we actually only need 1. The other one in females acts as a backup, but males don't have that backup. So if there's a mistake on a gene on an X chromosome, then a male will have the condition, whereas a female will generally be a healthy carrier. So here, half of this lady's eggs have the mistake and half don't. If she passes the mistake to her son, he has no backup and he will have the condition. But her other children will be healthy. If a male carries a condition that is on the X chromosome, he will either have X sperm that have the mistake or Y sperm that don't. X sperm make baby girls, Y sperm make baby boys. So none of his children will have OI, but if he has a girl, she will be a carrier. All of his girls will be carriers, but they should be healthy. And his boys, to be boys, had to get his Y, so they will be unaffected because the mistake's on his X. So this is rare, but happens. So the first thing for planning a pregnancy, if people do want to have genetic testing, or even to think about what the chances of having an affected child are, the first thing to do is some genetic testing. This does give us clinical information. It gives us information on what's likely to happen, what other things might happen, whether there might be hearing loss, whether there may be other complications. It does help make testing possible in other family members who may be interested to know if they, many people have some fractures, that doesn't mean they have OI. So sometimes when you've got the genetic change in a family known, it allows us to screen family members and give them better information. It does allow people to make different reproductive choices, but it's important to know that we don't always find a genetic change in a person with a bone fragility condition. We're getting better and better at it, and you saw from that list there are now many, many, many genes, but a person can have a bone fragility condition and we don't find the genetic change, which sometimes it makes people feel better, but sometimes makes people feel frustrated. And it just is what it is. So, can we test in a pregnancy, or can we avoid passing it on to a pregnancy at all? So as I said, I'm just going to come back now to these options over here. So again, the decision whether to test a pregnancy or not is a very personal one. And people may choose to test a pregnancy to inform decisions around delivery. There may need to be special precautions for the parent, for the mother, or for the baby, and the baby may be delivered in a bigger centre. So sometimes couples choose to do testing in a pregnancy just to prepare psychologically, or to prepare for a delivery to make sure that everybody's as safe as possible for delivery. But sometimes people test a pregnancy to consider whether or not they'll stop a pregnancy for an affected child. And sometimes people test a pregnancy with no intention of stopping a pregnancy and change their mind. And sometimes people test a pregnancy with every intention of stopping a pregnancy and change their mind. So how you feel and what you think is just really fluid depending on your experiences and where you're at. No one knows how they're going to feel until they're actually there. I mean, I had the same experience just when I had my kids, thinking about whether I was going to have a test or not. And I'm a geneticist, I do this every day. And I thought I knew exactly what I was going to do. And then I got there and it was completely different to what I thought. So these are the traditional options for testing during a pregnancy. So this is someone who turns up pregnant and says, I'd like to test my pregnancy to see if my child has the condition that I have. Or my child has a condition of a previous child I've had. And there are 2 ways that this is generally done. There's a CVS, which takes a little bit, so this is the cross-section of a woman, taking a little bit of the placenta with a needle that looks very long, which the placenta has the same genetic makeup as the baby. So if we test the placenta, we can tell whether the baby has the genetic change that we're looking for or not. And that's generally at about 10 or 11 weeks. The other way we can do this is a little later by taking some of the fluid around the baby in the pregnancy, because the fluid carries baby cells, that swallowed cells, peed cells, skin cells that go into the fluid. Generally, we do this when the genetic cause is known in a family and it's something that's planned or sometimes unplanned, but we know the genetic cause. More and more people are picking up subtle changes in the bones, sometimes not so subtle changes in the bones, on detailed ultrasound during a pregnancy. And we now can offer quite detailed genetic testing during a pregnancy to work out whether one of the known genetic bone conditions is present and try to give couples some idea of what that might mean. And that's not always easy. Sometimes we find things we really don't know how to predict what the future's going to hold, and sometimes we have a clearer picture. So this is a lot more available than it used to be for couples where it's new in the family. This is an interesting testing process that has been available for chromosome conditions. So conditions like Down syndrome is where you have a whole extra volume, number 21. But you can have extra missing of any of the chromosomes. And this testing actually is non-invasive. So those CVS and the amnio, they have a chance of causing a miscarriage. They're quite invasive tests. They involve a big needle, and there is a risk of causing a miscarriage following them, albeit small. This is called non-invasive prenatal testing, and the genetic technology is such now that you can detect and differentiate tiny amounts of fetal DNA that floats around in the mother's circulation, can differentiate that from the mother's DNA and see if certain genetic changes are there. At the moment, this is largely used for things like Down syndrome or abnormalities that are really big, like extra whole volumes or missing volumes. But this is changing, and it's certainly potentially available for genetic changes that are not usually present in the mother's circulation. So if you've got if you're pregnant with a baby and it's the dad that has the condition, OI, and that mutation is present in the mother's blood, then it must be from the baby. So you know the baby must be affected. This can also potentially work for germline mosaicism when the mutation shouldn't be there because it's not in the blood, but we find it. So we're only just starting to access these technologies for some specific genetic conditions. But I think this doesn't bring the testing earlier. It's still at 10 or 11 weeks, but it does allow people to avoid the invasive testing and the risk of miscarriage. Okay, so let's get on to IVF. So just as a concept, so this is pre-implantation genetic diagnosis. Sometimes people use testing, PGT, sometimes they use D. In concept, you get your eggs, you get your sperm, you fertilise them, that makes an embryo. You test your embryo, you freeze it while you test the DNA that you got, and then once you've got your result, you transfer back to the uterus an embryo that doesn't have the condition. In theory, it's possible for just about any condition that can be tested prenatally. You need to know what the genetic cause is, otherwise you don't know what to test for. It's a lot more technically challenging than testing from a prenatal test, a CVS, because you've got tiny amounts of DNA. So you've got maybe 5 cells from an embryo, whereas from the CVS or the placenta, you've got thousands and thousands of cells. And it's expensive. And that's changing with the recent introduction of a Medicare rebate, but it's still more costly financially than the other options. So it's worthwhile at this point reflecting, I think, on the timeline around PGD. The first successful sexing of rabbit embryos happened when I was born, 1967. But it wasn't until IVF really took off in the early 80s that this started to take off as a technology. The first successful PGD was done for sex selection in the early 90s. I joined Genea in 2008. These are all the technologies that we've moved through since I've been there. And there are various new and complex technologies on the horizon. So PGD or PGS, or pre-implantation genetic testing, can be used for a number of different things, not just testing for a specific condition. So this is where I mostly get involved when a couple has a condition themselves, or they have a child with a condition that they would like to avoid. But it can be done for sex selection, for medical things like autism or breast cancer. It can be done for finding a bone marrow match or a bone marrow donor for a child with a condition like thalassemia, rather than just taking a chance. Or we can just screen embryos for things like Down syndrome or other chromosome abnormalities that increase as women get older. So as I said, you collect the eggs, collect the sperm. We usually fertilise the eggs using what's called ICSI. So standard IVF, you just put an egg in a dish and you put some sperm in there, millions of sperm, and one gets in. But all the other sperm are around the outside of that embryo. And when you come to take your biopsy, you risk contaminating that sample with DNA from all of these other heads of the sperm. So the international guidelines say that we should pick a sperm under a microscope that swims well and looks good and inject it directly into the egg. And that's done all the time for people who don't have many sperm or whose sperm don't swim very well. But here it's for contamination. So once the egg is fertilised, it's called an embryo. And it has a set of chromosomes which can copy themselves. They pull apart and split into 2 cells. And then the chromosomes copy themselves, pull apart and split into 4 cells. And that continues all the way. But on day 5, the embryo looks a bit like a soccer ball. And it's got about 100 cells in it. It's got a layer of cells around the outside that becomes the placenta. It's filled with fluid. And then there's a clump of cells in the middle here that becomes the baby. We don't actually touch that clump. We take some of these outer cells because they should have exactly the same OI gene as the inner cell mass. And hopefully, with a little bit of luck, I might need to do it on here, mightn't I? Always need a bit of luck with a video.
This video demonstrates a technique known as embryo biopsy. What you see on the screen is a 5-day-old human pre-implantation embryo.
That's the embryo.
Very small amount of what is called the trophectoderm is going to be removed and evaluated to see if the embryo is normal. The center of the screen shows a target, a circular-shaped image, and the target corresponds to a non-contact microoperative laser that is used to remove, by a series of pulses, about 5 to 6 cells of this trophectoderm material. On the left, there is a dense blob of tissue still inside of the eggshell or zona. That blob of cells is called the inner cell mass, and those cells are going to become the embryo itself. The material that was just removed from this embryo is material that would otherwise be destined to become the membranes of pregnancies, such as the placenta, and other membranes. This piece of tissue, which you'll see being injected from what we have called the biopsy pipette, will then be placed in a tube and sent to a testing facility where we can evaluate the embryo for any number of different genetic heritable disorders.
It's always a miracle when that works.
This video...
So I think what's amazing in this is how strongly holding on those cells are. So the embryo is in a shell and does have to hatch. And sometimes the embryo doesn't hatch in time. It could be a healthy baby, but if it doesn't hatch by day 5 or 6, we can't indefinitely keep an embryo in a culture dish. It really needs to go back into the uterus. So there are sometimes embryos that just can't be tested. So the process is not a perfect process. So I just thought I'd give you some examples of families that I've seen over the years with various different types of OI. So this is a couple who had a son who died early in his life with a severe form of OI, which was shown to be autosomal dominant. And they had testing, and I don't know how, yes, and they were negative in their blood. But they went on to have another pregnant, naturally conceived, and unfortunately it became clear on ultrasound that this baby had the same very severe form of OI. So now they knew that this genetic change must be present in either the mother's ovaries or the father's testes, and that the chance to have another affected baby was up to 50%. So they then went on and had IVF and PTD and selected a healthy embryo. Probably the more common situation I see, where I've seen many couples, is where one of the parents has OI, and sometimes, you know, as you say, multiple members of the family have had OI and all lived long, productive lives, but they'd quite like not to have their child go through what they've gone through, but they wouldn't terminate a pregnancy for what they have. So for me, I see two groups of people: people who've had very traumatic time with very severe conditions, and people who have a condition themselves which they've coped with fine, but they'd really rather not have their child go through the same thing if they could avoid it, but they wouldn't terminate a pregnancy for it. So this gentleman had multiple fractures, he had hearing loss, as I said, added many, many members of his family, and they decided not to have a natural pregnancy because of the 50-50 chance of passing it on, and he had 2 healthy baby girls. And another last situation here with a recessive form of OI. This was a couple who had a baby who died in utero with a very severe, rare recessive form of OI, and they had a very traumatic time and did not want to go through another termination of pregnancy, so had and understood the 1 in 4 chance of recurrence for them, and went through IVF and had a healthy baby. Don't know why all my healthy babies are girls here. There's no particular reason for that.
I was going to ask.
No, it was just random. These are conglomerations of the families I've seen, so if you won't see yourself there if you have been through the process. So obviously there are risks. Yes?
Third example, did you have to check from the first, what is child, the same gene?
Yeah. So here, this couple had genetic testing of the DNA from this pregnancy, from this baby, and that the genetic change was found. I forgot the name of the gene. It was a gene I didn't know. And once the genetic change was found, both parents were tested and shown that they carried 1 copy. And then we knew that there was a 1 in 4 chance. So we tested just for that gene and just for that spelling mistake in the embryos.
So it has to be that exact same, that's what's going to
Yeah.
exact same, whether it's a microdeletion or that.
Or a spelling mistake, yep. So we can screen embryos for chromosome abnormalities. So that's looking to see whether all the volumes are there, things like Down syndrome. And we screen for that because that's a background chance that everybody has. If we're looking for a specific condition, we don't yet have the technology or the ethical and the frameworks to be able to do a spell check, if you like, on the DNA from the embryo. So we only design a test for a specific condition. I think that will come, where we can just screen the entire embryo for everything. But at the moment, just the technology, but also our ability to predict what those changes mean is just not good enough.
You can check if you do a blood test for the majority of things once the child is born, is that correct, but not on an embryo?
We don't, so in terms of, so you're talking about screening for things randomly.
Yeah.
So we don't tend to do that in us, but unless, so there is a new form of screening, which is called reproductive carrier screening, which parents can have when they're planning a pregnancy to look for hundreds of recessive conditions like cystic fibrosis, like spinal muscular atrophy. There are a few OI conditions on those panels, but not many, because the recessive ones tend to be rare. And that's done for a certain number of conditions again, but that's done before we plan a pregnancy. And they're for things we carry. Any other questions? Yes?
Yeah, look, I've got 3 children. Olivia has OI, my other 2 children don't. So, technically, the OI that we both have, can someone have, say, OI type 3 and have a child with a different type of OI, or is that the same?
My understanding is that, and Prof Jones might speak about this, my understanding is that the types are generally a clinical description. They don't necessarily correlate with the underlying genetic cause. So there are two ways to think about OI. There's the clinical type. I don't think they'd call it. Anyway, would you like to speak to that?
Well, that's
Yeah.
exactly right. So the Selets types are clinical phenotypes or clinical combinations of different features. The nosology now, or the naming of all these are now by individual genes.
Yeah.
But if you look at every one of those disorders, there's variability.
Yeah. So I think a certain gene can be associated with different types of OI, and it can even be in the same family, but you know, the variability. So we think about, I think about it in terms of the underlying gene, and then when I get to the underlying gene, then I can look at what variability is associated with that gene. So you tend not to get very mild OI in the same family as perinatal lethal OI. So that spectrum tends not to happen, but you can have a lot of variability in the milder forms. The severe forms tend to be more the same.
But it's the same spelling mistake.
Exactly the same spelling mistake. And so there must be other factors, other genetic factors, other environmental factors that alter the way in which something expresses in an individual. So what are the risks of this? Well, in general, in this process, there's IVF, and then there's the genetic testing of the embryo. And you know, millions and millions of babies are born by IVF every day. It's generally considered a very safe process. It's not, but of course everything has risks. Very important thing is that the biopsy, so taking those cells from the embryo, doesn't appear to add any additional risk in terms of the health of the baby that's born. So the embryo may not survive the process. Sometimes embryos don't make it through the process even if you do nothing to them. And if you fiddle with them and you freeze them and you defrost them, sometimes they don't survive. But the biopsy does not increase your chance of autism or intellectual disability or prematurity. It doesn't change that. When you look at IVF pregnancies compared to naturally conceived pregnancies, you do see a slightly higher chance of babies with problems in that group. But you have to remember that the vast majority of people having IVF are doing that because they have a fertility problem. And there are many, many fertility problems that not only make it hard for you to have a baby, they can increase your chance of having a baby with a problem. So we think that couples who come to us purely for IVF for genetic testing probably don't have any increase in risk of other problems. But we can never be 100% sure that the process doesn't somehow increase the risk of problems in a baby, but if it does, it's very, very small and we can't easily detect it. Of course, the testing could be wrong. Now, any genetic test can be wrong. Genetic test in blood can be wrong. Genetic test on a prenatal can be wrong. It's pretty rare, but it can be. Yes?
If it's a DNA mutation, is it known if it's a substitution, insertion, or deletion?
Say that again.
If it's a mutation, if it's not inherited, is it known if it's a substitution, insertion, or deletion?
Well, everybody's different. So when we go looking at a person's DNA, we can see whether it's a substitution or an insertion or a deletion. We look for all of those. And we can test for all of those in an embryo. Some are more challenging than others. Sorry? She's asking about different types of spelling mistakes. So spelling mistakes can be, your whole page can be missing. Or you can have a paragraph missing, so that's a deletion. You can have a word missing, that's a deletion. You can have an A instead of a T, and that's a substitution. What was?
My bio teacher described it as a soccer team, so substitution or insertion or deletion is one of the things on the
Yeah, just like a soccer team. Some people talk about it like a recipe. You're making a cake, you might leave the flour out, you might put, bicarb in instead of flour, as my daughter did, and then everybody vomited. Anyway, but any sort of mistake, that can muck up your gene, the vast majority can be tested for. But testing's not 100% accurate. In my 15 years of consulting at Genea, I'm not aware of anybody ever having a baby with a condition that was tested for when it was offered at the full accuracy. Genea offer their testing at more than 99% accuracy, but they'll never give you that last 1%. I've never seen it happen, but theoretically it can. We're working with tiny amounts of DNA. So some people still have a test during the pregnancy. No point if you wouldn't stop a pregnancy, you just have ultrasounds and see how you go. But nothing is 100%. And of course, it might not be successful. It depends on maternal age. So maternal age, as women get older, they have less eggs, and there are more chromosomally abnormal eggs there. So it gets harder as women get older. Many of the couples I see actually have tried naturally and not succeeded. So they're doing IVF anyway, and they add in the genetic testing. And obviously the genetics of the condition. Some people have a very small chance of having an affected embryo, whereas some people have a 50% chance. And that will obviously affect the number of embryos that you have available. Many things affect the choices that people make. Obviously your own experience, the experience of your family members, and your perceptions of a condition. Your religious or moral beliefs. I had a very interesting discussion with a couple last week where the woman said to me, well, but this is just abortion, isn't it? I said, well, it really depends on how you look at it. Some people think of every sperm as being sacred. Other people think that it's fine to be 120 days before it becomes the wrong thing to do to terminate a pregnancy. Some people would never discard an embryo. Some people find that that's the better of the different choices in front of them. Everybody sees it differently. There are feelings of guilt. I mean, having children is just one big long guilt trip, I think. Feelings of responsibility. Most of these things, all of these things, there's nothing we could have done about them. Our kids get all our good things as well as the things that we don't particularly want them to get, and it all comes in a package. But those feelings of guilt are often very hard to shift. Sometimes people are not on the same page. So that particular couple, the parents were on very different pages. The husband just wanted a boy, which we couldn't do, and his wife was really worried about this being the wrong thing to do anyway. So, people come on very different pages, and that's one of the jobs of our role, is to help people get onto the same page, or at least to find a way forward. And sometimes other family members can be really meddlesome. Sometimes it's helpful to have other people's involvement, and sometimes it's really not, and every family is different. It depends on your reproductive history. You might have, terminated a pregnancy in your teens and just couldn't ever face doing that again. Or you may be completely bright-eyed and bushy-tailed and have no experience at all and be going into it with a very different view. And then, of course, there's the economic and practical side of things. This is a bit of a busy slide, but really I just wanted to remember to talk about equity of access. And when I first joined Genea in 2008, the first thing that we did was put in an application to Medicare to try and get funding for the PGD part of the IVF process. And that was 15 years ago, and it's only just happened. The costs, so you have the cost of the IVF itself, the cost of the ICSI, you have the cost of taking the biopsy from the embryo, the cost of making a test, you have the cost of testing and running that on that tiny amount of DNA. Then you've got the cost of putting the embryo back and the cost of storing any embryos that you don't need or don't want to use straight away. Some people manage to get their whole family out of one cycle because they have frozen embryos. Others need to have more cycles. The costs differ enormously. At the moment, whilst there are a lot of IVF providers, there are not many that include PGD. So when I think about IVF providers, there are top tier IVF providers where you get all the bells and whistles. There are sort of middle of the range, and then there are budget IVF providers. None of the budget ones will do PGD at the moment. None of these companies make any money out of their PGD because it's very time consuming and difficult, and they don't actually make a significant margin on it. So the budget ones won't do it. There is only one truly public IVF provider in New South Wales at the moment, and that's there's only one truly public one, and they also now do PGD, and that's at the Royal Hospital for Women. And so they provide public IVF. There is still an out-of-pocket cost. I think it's about $2,000. And then their PGD, the embryo biopsy and testing is done at Genea. So it's of the same quality and complexity as the best you can get. I'm a bit biased there, but they do it. The genetics at Genea is very, very good. Then there are the top tier providers such as Genea, IVF Australia, Monash IVF, that all, I think, and it's very hard to work out what they actually provide the full suite of IVF, of PGD testing. So there are some simple tests that are fairly easy to do, and there are others that are more complex. And not everybody provides the more complex ones. Yes?
Can I just ask, is there any way that young women and even late teens can actually get their eggs just looked at first before going right into the whole process? Because I got my parents tested and then found out I just started the gene, but then I went in, had the internal ultrasound and I only had 2 eggs. So that's kind of a waste of time and money.
So there are two, so you can go in and have an assessment of your fertility. So that's the first thing. And they can give you an idea where your hormones are and how many follicles you have in your ovary. So your ovarian reserve. If you're young or you have concern that you're going to have early menopause, you can freeze your eggs, but you can't test them for OI. You can test eggs for OI, but then you can't use them because you have to break them down. Same with sperm. So you can test sperm. People always ask, can't I just test the sperm? Well, you can, but then you've broken it up. So you can store eggs, freeze them. It's not nearly as successful as frozen embryos. So, I met a couple a few weeks back where they were in a new relationship. She wanted to have PGD at some stage because I think she had breast cancer. So she needed to make some decisions. She made some embryos with her partner, but she also froze some eggs just because she wasn't 100% sure how that relationship was going to go. But the frozen embryos are far more successful than the frozen eggs. Does that answer your question? And so previously, there's always been a Medicare rebate for IVF. It depends on, and how much it costs you depends on how much gap that particular provider has, whether you've got private health insurance. There previously was no rebate for the workup, the making of the genetic test, for the biopsy of the embryo or the testing of the embryo. And they're the rebates that have been introduced in November last year, and they've made a big difference to the affordability of this process. At the moment, there is still a gap, and I think it's about $800, or I could be wrong. They're all so different. So I think that the cheapest place to go through IVF and PGD at the moment is the Royal Hospital for Women. I think it's about $2,000. I think you will still end up about $5,000 out of pocket, I think. But all of these places, so I don't even give out money figures for Genea because they change them all the time and everybody's different.
I don't know how many embryos do you, Kristi?
Yeah.
What do they do for embryo biopsy fee, or if you have more than 5, it's like a bundle?
So they cap it. So yeah, you pay, if you've only got 1 embryo, you pay for 1. If you've got 2 embryos, you pay for 2. If you've got 3 embryos, you pay for 3. If you've got 8 embryos, you pay for 3. I think that's right, it could be 5, but yeah, it's capped.
Is OI covered under the serious genetic disorder?
Yes. Well, that's all it says, so it's up to us.
Okay,
So whether a condition is considered serious is up to the person with the condition largely. So I'm there, and I've got 5 minutes. I'm there to put some framework around it. So occasionally I will say, look, I just don't feel comfortable with that. But generally, if a family feels that the condition they have is serious, then who am I to say that it's not? So that's actually reflected in the outcomes. I think that's the end of, yeah. We think of pros and cons like this, but actually it's more like this. Yes?
So I have 3 children without OI, and my daughter's asking me, she's 19, like, can she pass it on? Is it the simplest answer just to get tested?
Yeah, to go and see a genetics unit.
Yep.
So if she goes to see her, so they'll need some information about your OI and your genetics, and then either will be, look, actually, you don't have what we don't have to test. Sometimes we still test people just for reassurance, even though we know it's 99.9999% not going to be there. But yeah. Yes?
Alan and myself
we'd start with her. Because when a person's the first affected in the family, they might have a recessive form where both parents carried it and they have a recessive form, or they might have a new dominant form, so where it's just happened for the first time in Hayley. So we would always start with Hayley, do some genetic testing, work out what type of genetic change you have, and then we can tell you whether actually this is very unlikely that you're going to have affected children, or 50-50. It sounds like you're on top of that already, though. The thinking. Your biology questions were very good. Any other questions? Yes?
Do you see emerging technologies like CRISPR-9 having any impact in?
I think they'll have a huge impact. I just don't know when. So.
Is it about the ethics that's holding us back? Or?
No, I don't think so. So CRISPR-9 is a gene editing technology where you go in and you try and snip out and fix the genetic mistake. So rather than avoiding the embryos with the condition, you try and fix it. There are lots of technical issues in terms of off-target effects. They're not very good at just fixing that one mistake, and also not as efficient in fixing it in every cell. And in OI, for example, you've got to get into the bones.
Well, I'm thinking about the doctor in China,
Yeah.
because, you know,
Yeah.
After you fix those genes, they are out there in the world, they can be passed down.
Well, that's if you do it in the germline. So you can edit our genes in our bones and our blood and not affect our ovaries or our testes. So we won't be altering our genes as they're passed on. The doctor in China did a very stupid and unethical thing, I think, and tested and altered the genes in an embryo for an HIV resistance, to try and get HIV resistance. And it caused a whole sort of flow-on effect of angst and frustration. And those children, I don't know whether they'll be followed up. But the ethical issues are really important, but I don't think that's what's slowing it down at the moment. I think what's slowing it down is just technical things. Yeah. I think my time is up.
Sorry, I think you were hanging around just for a little while longer.
I'm happy to.
Yep.
Yep.
So if you have any other questions, please feel free to come up and ask her any other questions. Thank you so much.
Pleasure.
Definitely,
Thank you for having me.
Questions that we all have to answer for ourselves. And it's just a little thank you.
Oh.
Just a little
Thank
thank you.
you.
From our society.
Thank you very much.
So much.
Thank you.